Hello, everyone. Welcome. We are so excited that you could join us today. We plan to use this time together to introduce you to the new NCCRT Messaging Guidebook for Black and African American people, Messages to Motivate for Colorectal Cancer Screening. Today's webinar will be recorded and shared following our presentation, and we will make slides available for you as well. And you can find those all on our website. So the purpose of today's webinar is to give you a sneak peek of our guidebook. And just so you know, we're currently in the last stages of the review and approval process, but we're hoping to have it available to you all in the next few weeks. As this process keeps moving forward, we're going to keep you informed and let you know about our release schedule. You're going to hear an overview of our market research, be introduced to preferred messaging channels and trusted sources. We're going to share top-ranked CRC messaging from the research and discuss upcoming publications as well as new NCCRT resources. And we have designated time for question and answer. So I just want to remind you all, you should see a Q&A box on the right-hand side. So please put any of your questions in that box and we'll get to them at the end of the presentation. I want to quickly thank Quest Diagnostics for providing funding, guidance, and support for the market research and the development of this guidebook. I'd also like to thank the NCCRT Public Awareness and Social Media Strategic Priority Team, our advisory group members, the Association of Black Gastroenterologists and Hepatologists, the Anthem Foundation, and the American Cancer Society for providing additional support. Now, my name is Caitlin Sylvester. I am co-director of the National Colorectal Cancer Roundtable, or NCCRT, and I'm very excited to share with you our wonderful presenters for today. We have Michelle Aubertine, project consultant with KSNR, Dr. Fola May, Director of Gastroenterology Quality at UCLA, and Dr. Ajua Enyene-Ioba, gastroenterologist at Massachusetts General Hospital and Harvard Medical School. I want to give a brief overview of NCCRT. We are a national coalition of public, private, and voluntary organizations dedicated to reducing incidence of mortality from colorectal cancer in the US. Now, we do this through coordinated leadership, strategic planning, and advocacy. We were founded 25 years ago by the ACS and the CDC, and we have over 150 partnership organizations. We work throughout the year through our strategic priority teams. We host special topic sessions, and we meet every year, generally in November, at our NCCRT annual meeting. Now, all of our work is really driven through the 80% Every Community campaign. And this is an NCCRT initiative in which more than 1,800 organizations are working toward this shared goal of reaching colorectal cancer screening rates of 80% or higher. So through dedication, determination, and collective action, we are seeing that rates of 80% and higher are possible, but we're also seeing that not everyone is benefiting equally. So while we've had many successes, there's still much work that needs to be done. As part of the 80% campaign, NCCRT has produced a suite of messaging materials available to the public. In 2014, we conducted our first market research project among adults eligible for colorectal cancer screening to better understand barriers and emotional motivators behind screening. This research was important because following the adoption of ACA, we had a tremendous amount of people who now had health coverage, and we wanted to be sure that we could develop materials to encourage them to get screened. This research resulted in the first iteration of the NCCRT Communications Guidebook, which quickly became a vital and leading resource for our NCCRT members and partners. Following this success, we invested in additional market research, and in 2019 released the NCCRT Colorectal Cancer Screening Messaging Guidebook, Recommended Messages to Reach the Unscreened. So following the success of these guides, our public awareness and social media strategic priority team sought to create a supplemental guidebook focused specifically on Black and African American people. This work accompanies similar companion guides we've developed for Asian American communities as well as Hispanic and Latino populations. Over the last 2 decades, colorectal cancer screening rates among average risk Black adults has doubled from 32% to 65%. And in 2018, 57% of those aged 45 and older were up to date on screening. So while these rates are similar to those of white adults, colorectal cancer incidence and mortality rates are higher in Black communities. I just want to use this as a reminder that while this guidebook will provide important information to encourage screening, it's important to keep in mind that more needs to be done across the cancer continuum to tackle colorectal cancer related disparities. So thank you guys so much. I will now pass it to Michelle Aubertine, who will share about our market research.
So in 2021, the NCCRT and the ACS partnered with KSNR to conduct research on the perceptions of colorectal cancer screening among unscreened Black and African American people. The overall goals included gaining a deeper understanding of the barriers to being screened, which we had high-level insights on already from previous years' research, but we wanted to dig a little deeper. We also wanted to understand healthcare behaviors and perceptions, understand how systemic racism and social injustice impacts the Black community's experiences within the healthcare system. We want to uncover different motivators to encourage screening like we've done in the past, and then identify preferred and trusted information sources, as well as test potential messages to measure which ones are most likely to motivate screening and uncover why the top messages resonate with this audience. So to do this, we conducted 2 phases of research. We first conducted one-on-one in-depth interviews over Zoom with 10 Black and African American people ages 45 to 66 who had not been screened for colon cancer. The purpose of this was to dig deeper into the barriers to screening. We also wanted to understand the impact of systemic racism and social injustices on the Black community's experience with the healthcare system, and gain reactions to some potential messages to identify which elements are most effective. So we know from past research that there is an emotional element to barriers to getting screened. And that's why these discussions, they really help us tap into some of that more than any survey could. And then, when addressing systemic racism as well, there's emotion there, and a one-on-one conversation to start digging into insights there is a better fit. So learnings from this phase helped inform some of the survey inputs for the next phase of research that we conducted, and it also assisted with the message development. So for phase 2, the team had crafted 15 messages. Again, it was based on some findings we had from prior years' research, as well as learnings from the phase 1 interviews. We then conducted an unbranded online survey with nearly 500 Black and African American individuals who had not been screened, in order to test these messages to identify which ones would most motivate the audience to take action and get screened. We used an advanced analytical method called MaxDip to mathematically measure the impact of each message. Other objectives of the quantitative survey included quantitatively validating barriers to screening and general health perceptions, identifying how this audience prefers to receive health information and who they trust to give them that information. And really what's key here, with a base size of nearly 500 Black and African American individuals, it enabled us to dig deeper into the data and look at subsegments within the audience to see, do attitudes and behaviors, do the barriers to screening, do which messages are most motivating? Does that differ across different age groups, different geographic areas, gender? And then additionally, we were also able to look at those with the family history as well, which was helpful. So from this research, we obtained a lot of rich insights, and here, we summarize just some high-level findings to address that helped address our key objectives. So deferment, those saying they'll get screened eventually, they've just been putting it off. That's the top reason for having not been screened, and we'll go into a little more detail later on really what's behind that procrastination. With regard to systemic racism, about 1 in 3 report racial bias in healthcare makes them at least somewhat hesitant to seek out healthcare. In the interviews, some shared personal experiences where the care they received had been impacted because of their race. Others, they didn't have personal experience, but they knew someone who did. Overall, the consensus when we walked away from those conversations and when we validated it in the survey was there's room for improvement in the healthcare system to address these issues. The last 2 findings, they really highlight how discussions with healthcare providers, they aren't happening. The majority of those under the age of 55 had not had any discussions about CRC screening with the healthcare provider. And just slightly over half of Black and African Americans over the age of 55 have had a discussion about screening with their healthcare provider. So, what we're really seeing here is doctors not recommending it. It's also a top barrier as well. We saw that, beyond deferment, their doctor not recommending it is a reason it's not getting done. So now I'm just going to turn it over to Fola, who's going to talk through more of the market research results.
Thank you very much. So we use the very insightful information gained from this research to develop this new guidebook, which we've titled 2022 Messaging Guidebook for Black and African American People, Messages to Motivate for Colorectal Cancer Screening. And we're very excited to bring this guidebook to everyone, to the public, to use as a resource for your communities. And the guidebook, as mentioned, will be publicly available in a couple weeks. It includes an overview of perception and attitudes about personal health and CRC screening. It shares top identified barriers to colorectal cancer screening, some of which we knew before, but many that emerged from this research that was performed. It provides preferred message delivery channels and top trusted sources for relaying health-related information that's specific to Black and African Americans. We introduced the top 4 preferred screening messages that emerged from the market research, and we spotlight 4 groups of focus. Next slide. Black participants in the market research shared several perceptions and attitudes about their personal health that guided this work. When asked about common perceptions about their own health, 87% said that they care a great deal about maintaining their health. 75% said they knew what they needed to do to remain healthy, and 62% considered themselves healthy already. In regards to insurance and the medical home, 84% already reported health insurance coverage. 90%, so a very high proportion of those insured reported having a primary care provider. We also learned that 57% were already communicating with their primary care providers or a doctor through the patient health portal. As for seeking medical care, these data are a little bit different. Only about 65% of respondents and 51% of males said that they receive regular checkups. 58% said that they get a physical each year. A low 37% said they only visit the doctor's office when they're sick. Low number, but that's actually significant that they aren't receiving regular care. And 33% said that they avoid going to the doctor as much as possible, which I think categorizes many people. Next slide. So overall, we found that many unscreened Black and African American individuals, as shown on the previous slide, were really focused on maintaining their health, and they knew what they needed to do to stay healthy, including seeing a doctor for regular checkup, although we know that the regular care, seeing doctors when it's not necessary, was lower than anticipated or than we desire. We also learned a great deal from participants who shared what was the top of mind thought or idea that came to mind when they thought about colorectal cancer and colorectal cancer screening. And I thought these are really interesting in reviewing the data. So there were participants that responded that there was suffering that was caused by colorectal cancer and this suffering is unbearable. Respondents said that colorectal cancer is one of the more unpleasant forms of cancer, frequently stating that it results in death. Respondents stated that there was a moderate chance of survival if diagnosed with colorectal cancer. And we all know that if we detect this disease at stage 1, the survival is actually upwards of 95%, 90 to 95%. Top of mind thoughts also included that there was discomfort, both mentally and physically, associated with the screening exams, probably referring to colonoscopy, but also the stool-based studies. Those with a family history of colorectal cancer acknowledge screening is important despite not completing screening themselves. So again, having the information to know that they need to be screened, but not taking action. There was also the belief that living a healthy lifestyle reduces one's risks of colorectal cancer, which I think we all have seen. I eat well, my stools are normal, I can't possibly have colorectal cancer, so I don't need screening. So that definitely emerged in the research. And also, unfortunately, as we've seen in some of the other research, there was the perception that colorectal cancer is common in men, but women sometimes can be and also not be diagnosed with it. So some confusion about that. Next slide. We also learned about the barriers to screening. And for me, this was important because there is a lot of information out there about barriers to colorectal cancer screening that have emerged in research over the last couple decades. But now that we've included this younger group of individuals, 45 to 49, and as the cancer landscape has changed, We're curious to know if those barriers have changed. We were also in the middle of a COVID pandemic. So when we looked at the barriers to screening that emerged from the market research, the top 3 reasons for delaying screening were: number 1, deferment, so just deferring the action; number 2, reporting a lack of family history or symptoms as a reason for not being screened; and number 3, a lack of a doctor recommendation to be screened. And we know that doctor recommendation is the number 1 predictor of whether an individual receives screening. A little bit more on those who deferred. There were many reasons why people reported deferring colorectal cancer screening. COVID-related and financial concerns were common, and many unscreened people also noted pressing issues in their life unrelated to screening or to health that prevented them from getting screening. Some examples included caring for family members, maintaining a hectic work schedule, dealing with other financial issues. Interestingly, participants who were under age 50 years of age also indicated that they feel they're less likely to get colorectal cancer and postponed for that reason, again, prioritizing other things. Conversely, the group of individuals who is over the age of 55 stated that screening was deferred due to concern about the screening test and fear of getting an abnormal result. So this idea of cancer fatalism, that if I get screened, I'll be diagnosed with cancer and then I'll have something else to deal with in my life. As I mentioned, then the other top reason for delaying screening was reporting no family history and no symptoms. So those individuals who had no family history of colorectal cancer and no GI symptoms were more likely to delay screening. A third of unscreened people felt that screening without a family history of colorectal cancer was unnecessary. And 10% of unscreened people thought that only those who had symptoms consistent with colorectal cancer should be screened for colorectal cancer. So again, we have some work to do in that area. However, most indicated that they would be comfortable discussing screening and related key issues with their doctor. And that last big major category for barriers to screening was that the doctor did not recommend screening. The majority of individuals under the age of 55 had not had any discussions with their medical doctor or any healthcare provider at all, for that matter, about colorectal cancer. And just about half of those age 55 or older also reported discussing screening with their providers. So it appears that as people get older, that discussion comes into play, but unfortunately, under 55, those discussions are not happening in the doctor's office. While doctors and other healthcare providers initiated 78% of the conversations about colorectal cancer screening, only a small number of respondents or participants, about 22%, indicated that the doctor emphasized the importance of screening. So I always like to stress that there are patient-related factors to lack of screening, but there are also a lot of provider-related factors here, again, emphasizing that there are interventions that are needed on the provider side if we really want to eliminate these disparities. Next slide. In order to determine the preferred messages in this population of individuals, 15 crafted messages were tested using advanced analytics to determine which were more impactful in encouraging unscreened Black and African American people to get screened for colorectal cancer. These message themes were based in 5 areas. The concepts listed here on the left side of the screen, in that colorectal cancer is preventable and treatable if caught early. It's a silent disease, so again, not requiring symptoms. A message theme that also emerged was family history, that there are multiple screening options, and cancer facts related to Black and African American communities. So specifically making that messaging tailored towards Black communities. And as you can see on the right here, the message performance really varied quite extensively on that message, but there were clearly some that were more attractive or more appealing to those who participated in the research. And on the next slide, I'll talk about the top 4 messages that emerged. Next slide, please. Perfect. So these were the top 4 messages that emerged. Number 1 being this message: did you know that colorectal cancer is the 2nd leading cause of cancer death in Black and African American people in the United States? Colorectal cancer can be caught early or even prevented through regular screening. most people should begin screening at age 45. So very clearly stating the risk and stating that you potentially can reduce your risk. The number 2 preferred screening message was as follows. Colorectal cancer is often a silent disease. Usually there are no symptoms. That's why getting screened is so important. Screening can help prevent colorectal cancer or catch it early when it's easiest to treat. Most people should begin screening at age 45. The third most preferred message was colorectal cancer still happens more often in Black and African American people, but progress has been made. Fewer Black and African American people develop or die from colorectal cancer as compared to just a few years ago, thanks to more Black and African American people taking part in screening, which now starts at age 45. So this is instilling a sense of hope that there's something that you can act on and change the risk, and that we are making strides in getting more people screened. And people are going to respond to different messages, but certainly moving more towards fear versus hope are going to have different people or catch different people's attention. And the last preferred screening message was, right now, you could have a polyp, a small growth in your colon or rectum. Right now, your polyp may be harmless, but over time, it could develop into colorectal cancer. Right now, through regular screening, you have the power to find and remove precancerous polyps and prevent colorectal cancer. Call your doctor and take control of your health. And I really like that one because I think a lot of people don't realize the power we have with colorectal cancer, and that we can prevent the cancer in the first place by removing polyps before they have the opportunity to transition into cancers. So this is providing that education that there's a pre-cancer form in the form of a polyp. Next slide. Our number 1, our top message, which again is repeated at the top of the slide here, really highlights some of the preference findings from the research. We were able to learn why this message really resonated with people. It's important to know what's effective, but it's important to also understand why it's effective. And participants stated that this particular message was helpful because it was a good warning sign. This particular participant said, I know that healthcare is for us is very different in this country. I appreciate knowing that colorectal cancer should be more of a concern for Black people. Other quotations are listed here. I really like the one that's towards the right side of the slide that states, because it sounds like it's speaking straight to me, because particularly in Black and African American individuals and communities, you feel that some of the messaging in healthcare isn't tailored or speaking to you. So this is exactly the hope that we had, that we would find messaging that would speak to our communities. I'm going to pass the torch. Next slide, please.
So how messages are received and from which trusted sources can have a significant impact on someone's knowledge and perceptions about screening. And so on the left here, you can see where people prefer to receive CRC information. And on the right side are the most trusted sources for CRC information. And so while advertisements and discussions with family and friends were found to be the leading sources of colorectal cancer screening information among Black and African American people at 47% and 35% respectively on the left, actually hearing this information directly from a medical doctor is by far the most preferred channel. And so on the right side here, you can see most trusted sources for CRC information, 86% doctors, and followed by 81% other medical professionals. In addition, receiving materials in doctors' offices, along with sharing of colorectal cancer-related information through email, websites, and patient portals were also top of the list. Many respondents also agreed that multiple modes of communication should be used to reach them. And most respondents also prefer to see a regular person they identify with talking about their experience with colorectal cancer or colorectal cancer screening instead of a celebrity. Next slide, please. So we also spotlighted 4 specific groups where messaging could be particularly impactful. And so the first group were people who feel impervious or people who feel untouchable. So this group was less likely to get screened because they have no symptoms and no family history. They also felt that they were less likely to develop colorectal cancer. And only about half of individuals in this group had talked to their doctor about screening. The next group were those who are concerned about cost. So this group often did not have health insurance. They often could not afford out-of-pocket costs, and they were concerned about treatment costs if cancer was found. The third group were those who were fearful. So they had heard that screening could be unpleasant. They felt embarrassed about the PrEP or screening tests, and they were afraid to find out if they had cancer. And the fourth group were those who were too busy. So this group was focused on other health issues. They're prioritizing the health concerns of those close to them, and they were unable to take off of work or make time for screening due to other obligations. And so for each group, we share their demographics, top barriers to screening, and the most trusted channels, and top 3 messages that resonated with that group in the guidebook. Next slide, please. So I'm super excited to share that we actually have a new publication coming out soon that details the barriers and effective messaging that we report in the guidebook. And so this will be another additional resource for everyone to use to tailor screening messages to Black and African American individuals. And so the new messaging guidebook is actually going to be released to the public in a few short weeks. So we're also very excited about that. And then in terms of next steps, we want to use the research to help change the way healthcare providers discuss CRC screening with patients, to tailor top messages to individual communities, and to have a greater focus on the entire continuum of care to reduce and eliminate CRC-related disparities. Next slide, please. So I also want to take a moment to share the NCCRT Resource Center and data page. So these are really rich resources to, get more colorectal cancer screening information. So the NCCRT Resource Center contains evidence-based resources and tools to help you increase quality colorectal cancer screening in a range of settings and population. And actually, this is where the guidebooks are going to be housed. And the guidebook that we're talking about today will be live there in a few short weeks. The NCCRT Data and Progress webpage provides up-to-date statistics on colorectal cancer screening, incidence, mortality, and geographic distribution information. So these are very, very helpful resources to use in your practice. Next slide, please. I also want to share another upcoming NCCRT resource release. So the NCCRT is updating the STEPS guide. And so the NCCRT STEPS guide provides step-by-step instructions to help health centers implement processes to increase CRC screening. So the 2014 edition has been instrumental in helping numerous health centers achieve improvements in their CRC screening rates. So the new guide will include the latest science and best practices, current guidelines and test options, expert-endorsed strategies, case studies of exemplary practice sites, and other samples, templates, and tools. And so please register for the webinar release. That'll be July 25th, 2022, and we'll share more about the STEPS guide at that time. Next slide.
Thank you so much to our wonderful presenters. We now would like to open it up to Q&A. And Yvonne, do we have any questions in the Q&A box?
The first question is for Fola. Can you remind the denominators for the data just presented in your presentation?
So for the qualitative interviews, which was the first step, there were 10 interviews. And for the national survey, that was 490. So the total was 500. Does that answer the question?
Yes, thank you.
Okay.
And the next question, I will open it up to all of the panelists. It said in the slides, it states that doctors are a trusted source, but there are also racial biases and medical mistrust. How do we work through those issues when we continue to hear about mistreatment in medical professionals when it comes to their African-American patients? I open it up to whoever wants to take the first answer.
Yeah, I mean, I can start, but I'm sure we all have thoughts on this. I think that we have a long way to go in many directions. And I alluded to this when I was speaking about some of the market research results. We tend to blame patients a lot of time when they don't participate in preventive health services, not recognizing that there are so many problems at the health system level, at the policy level, and at the provider level. So we have a long way to go to build trust in many communities, not just the Black community and the Latino community and the Native American or American Indian Alaska Native community. And I think that the only way really to build trust is to have these efforts where we are providing specific useful information that is going to help improve survival and reduce mortality in groups that are disproportionately impacted by diseases like colorectal cancer. And providers need to be aware of the conscious and unconscious biases they have when they provide care for patients. I, as a provider, have started to point that out even to some of my colleagues that even in a gentle way, you know, I don't feel that you would have presented that information the same way to a white patient, or I think you would have spent more time talking about that with a white patient. So sometimes it also is on us to help others see the unconscious biases that they have, and hopefully we can move our healthcare system towards more acceptance and better treatment and better equity and quality of care.
Thank you, Fola. As a follow-up question, it was placed that we've touched base on the fears, but how do we incorporate the lack of trust in the healthcare system? Adoja or Michelle, if you'd like to take on that answer.
So it's not necessarily a lack of trust. I think we need to be careful with that terminology. They trust that their doctors are educated, that their doctors know what needs to be done. If their doctor's telling them they need to be screened, that's who they want to hear it from. In the conversations, there's instances where they're weary to seek out medical, you know, they might hesitate, and it's somewhat hesitant to seek out medical care because they don't necessarily trust the treatment they might get is, there might be some bias to it, right? But at the same time, it's who they want to hear from their healthcare provider. And again, I think we need to keep in mind it was 1 in 3 say they're somewhat hesitant. So the majority of the base of respondents that we talk to, you know, aren't hesitant to get health treatment for those reasons. However, most acknowledge that it exists. There's disparities in the healthcare system. There's systemic racism. It's there, and they do think more can be done to improve it. But the majority are saying it's not making them hesitant to seek out care. I think you need to flip it and look at it that way.
And I think the hesitancy is on many levels, right? So we're using that term kind of in a singular way right now, but there's hesitancy to seek care in the first place. There's hesitancy to participate in care beyond when it's necessary, i.e. you have pain or an active symptom. And then, you know, you have to realize with CRC, especially in the case when we're recommending colorectal cancer screening through colonoscopy, you're referring to a different provider. So you can have complete faith and understanding of your own provider, but not trust walking into a different health system. I work frequently with federally qualified health centers. They have to send all their patients to other health centers to get colonoscopies. There's a lot of hesitancy about walking into a new facility to get care when you have never seen doctors in those facilities before. So we just have to recognize that it's the coordination of care, it's the comfortability with walking into an unfamiliar space to have an invasive procedure like the one that often comes with colorectal cancer screening. Adjoa, did you want to add something? I see you nodding.
No, I completely agree with everything that you guys said. I think in terms of the racial bias thing, I think as providers, really putting in the work. So understanding our biases, knowing what we bring into the room with patients, and really working to counteract that. So we're making sure that we know what we're bringing in, and we're treating each patient fairly, and really recommending screening to everyone. But I really think that you both really hit on all of the topics. And yeah, I completely agree.
Wonderful. To follow up, how do we address colorectal cancer screening that it's not being addressed by their providers or suggested by their providers?
I can talk about this. And so I think the first thing that's important is for people to recognize that, you know, providers aren't talking about colorectal cancer screening with all of their patients. And so I think the first thing is recognizing it's a problem and that it's something that needs to be worked on. And I think the next step is figuring out ways in which we can, really incentivize providers to discuss screening with all patients, but also figure out workflows or other ways that we can really kind of incorporate screening into the everyday practice and to ensure that we're recommending screening to everyone, and really thinking about being creative about ways that we recommend screening in terms of doing it through medical assistants in clinics or finding other avenues to ensure that even if providers are very busy, that we're finding other ways to offer screening to everyone.
And I'll just add to that, I agree completely with what Adjoa just shared. I'll add to that we can't depend on healthcare systems. So we shared this data, and there are many data that show that anywhere between 20 to 35% of people don't identify with a healthcare system or provider. So we are going to have a screening rate that's below 80% if we rely on going through healthcare providers and healthcare systems. And that's part of the reason why we formed the Association of Black Gastroenterologists and Hepatologists, because we recognized that there were a lot of individuals that didn't have connectedness to primary care providers, to gastroenterologists, who wanted trusted information from the medical world, but weren't going to get that in a health center or a clinic. So I think that organizations like ours, who are finding ways to educate the public outside of the clinic, outside of the hospital, and other organizations are doing this as well, are going to be critical if we really want this message to get to everybody.
Thank you. Thank you for your answers. Definitely gave us a lot to think about there. And Michelle, this question is directed to you. We have someone in the chat that is a community program coordinator at a medical institution, and they noticed that the community engagement and outreach was not listed as a trusted source for healthcare information. Are there any thoughts on how that could be used more effectively?
I'm the community, I need a second sentence on that. So it was not part of the survey. So within the survey, there was a list, and community outreach engagement wasn't really in there. We did trust on trusted sources, such as, and Caitlin, if you want to jump in here, such as their trust with their local church and things like that. But we didn't really dive deep into community outreach.
Yeah, but I think that's an important thing to note and something to consider. I also want to give, I've noticed some questions and comments in the chat as far as dissemination and different marketing and messaging materials. So in our evaluation, we have a question of what sort of resources you guys would be looking for. And so if you have ideas on how these messages can be tooled for community groups that do outreach, we would love to hear about them. And I kind of see this this work and this document as something that's going to evolve, and we want to, touch back and provide the materials that will be most helpful to you all.
And Michelle, really quickly, I think on that, there's some questions popping up, kind of some themes around social media and advertisements.
Mm-hmm.
Maybe you can reflect on social media. Kind of hasn't really popped in our market research in the past. So I don't know if there's anything, comments that you want to address on that.
Sure. So yeah, I see if I can address a few of these comments that I see in the chat right now. So with regard to advertisements, I think there was a question there that was asked how advertisements were positioned. And it was in the survey list, and we gave examples such as television, radio, internet, magazine, billboard advertisements. But when we, in our in-depth conversations and when we've done the research in the past, it's primarily when they say they've heard about colon cancer screening through commercials, it's people remembering the Cologuard commercials. Like that was the overwhelming majority when they select advertisement. And they give some very colorful recounts of those ads as well. With regard to Facebook, yes, it doesn't float to the top as a preferred or even a trusted channel. But what we learned is that virtually all people that we surveyed are on social media. So it does make it an ideal source to, for reaching this audience with CRC and CRC information. They're on it, they'll see it. It might not be the way they want to receive it, but I mean, we see it would be wasted channel not to use to reach this audience, given how widely it is used. And then I saw a question about 90% of the survey response has a relationship with the physician. I want to clarify that is just 90% of those with health insurance. So that does not include those that are uninsured, who we did survey.
And I think what I was saying earlier is exactly, I didn't see Matt's comment until now, but that's exactly the point I was trying to make, Matt, that there need to be efforts that are also focusing towards people who are uninsured and don't have a provider. And that's where a lot of the social media, the public outreach, some of the work that is really innovative work that's going to be coming out of industry, even some big corporate groups are starting to do work. I don't know if you've seen Cottonelle has been doing some work around colorectal cancer screening awareness in commercials as well. So I think that you have to use these other means to reach that 33% that you're mentioning, Matt, who avoid the doctor as much as possible.
Thank you. Thank you. They also has another question on how we can connect in a meaningful way with ACS, NCI, and NIH.
Caitlin, I'm going to let you answer. I feel like you already do, but I'm going to let you, maybe you can answer.
Yeah, I'm sorry, Yvonne. Can you say that one more time for me?
Yes, how can we connect in a meaningful way with ACS, NCI, and NIH?
I mean, yeah, that's a great question. And truly through the roundtable, that's what we're trying to do through one, the annual meeting. We try to invite all of these groups that touch colorectal cancer in various ways and are doing the work. Also, that kind of goes back into our dissemination plan. So as we get ready to release this resource, we're going to be looking for different ways to connect to our partners and disseminate these resources. And again, if you guys have specific ideas on the best way to do this or the specific groups to reach out to, we would love to hear about them.
Wonderful, thank you. There is a great question here, and I'm going to open it up to the entire panel. Is there any good evidence about the interest uptake of patient-initiated use of FIT test buying from CVS or LabCorp directly? Instead of getting ordered by a doctor, will patients do the test more likely?
So I haven't looked at any formal research that has looked at market-based screening. So as you're saying, like CVS provided, the way to think about that is screening that's not coming from a healthcare system or a provider versus screening that's initiated in a health system. I think that's hard to do just because with the market base, you don't have a denominator. So it's hard to measure what the uptake is because you don't know how many people that's exposed to. I think the biggest concern, and I'd love Adjoa to weigh in on this too, that I have about that approach is that with colorectal cancer screening that's stool-based, it's a two-step screening process. So we didn't talk much about the screening modalities today, but there are actually 7 recommended methods to screen for colorectal cancer as stated by the United States Preventive Service Task Force. We're very lucky that there are 7 ways you can screen for colorectal cancer. And several of these, including FIT is the most common, but also the Cologuard test that we referenced today are stool-based, meaning that you can perform them in the comfort of your own home by gathering a sample of your stool in a safe and clean way and submitting it to a laboratory where the laboratory is checking the sample for either microscopic or small amounts of blood or DNA that might be consistent with an early or late colorectal cancer. Now, the thing about these tests is that they are intentionally designed to be two-step tests, meaning that you do that first step of submitting the sample, and if it's abnormal, you have to have a colonoscopy because an abnormal result means that you could have a polyp that's dangerous or you could already have a cancer that needs to be addressed. So I get nervous about I'm going to call it the CVS approach, although I'm sure the CVS people wouldn't like that, because I worry about that second step. So what happens when you are a person who has no connectiveness to a primary care provider or physician and you're at home and you get a positive result? Who's going to make sure you get that colonoscopy? So that's the loophole that I think we just need to work on. I do think that there is a place for making these tests more available in as many settings as possible, but we need to make sure that there's navigation or throughput to colonoscopy for the 6 to 15% for some of these stool-based tests that will be positive or abnormal and that warrant a colonoscopy. So that's just how I feel about those tests.
And I'll chime in as well. And Full, I completely agree with everything that you said. I think it's, the accessibility in terms of being able to buy it from CVS or buy it from LabCorp directly is great, but there's definitely that fit to colonoscopy loophole, especially for people who aren't plugged into the system, that we would miss. But even for people who are plugged into the system, I would worry that, how are we going to get the results back to their providers? How are providers going to know that the patient never picked up a kit, or they picked up a kit and they didn't return it? And how are we going to make sure that this is done regularly and annually? So I think even for people who are plugged into the system, there are multiple steps and areas in where things can fall through the cracks. So I think, just like Fola said, making sure that there's throughput, making sure that it's, kind of a well-oiled machine is important, just to make sure that people don't fall through the cracks from fit to colonoscopy, but also throughout the stool-based testing process, because it's not just buying the kit, but it's also returning the kit and then following up results.
And it's possible. I'm not saying it's impossible. And one example of how I've seen it done effectively, I mentioned that Down There Care campaign that's being run by Cottonelle. And so what they do with that is they give out thousands of free fit kits to Black Americans every year, but they've partnered with the Colorectal Cancer Alliance, so CCA, and all of the people who return the kit and get a positive result, CCA actually calls those patients, helps them find local gastroenterologists or colonoscopy centers to get the colonoscopy done. So again, that's a perfect example of making these stool kits publicly available outside of a hospital or clinic, but including that second step that Adjoa and I are talking about to make sure that there's follow through, the colonoscopy is being done. And as Adjoa made a really important point, that's done every year, because doing a fit once and then waiting 10 years to do another one doesn't work. With these fit tests, you have to do it every year. With Cologuard, you have to do it every 3 years. I hope that answers. I'm looking at, now I'm being better at looking at the chat, and I think that answered some of the questions in the chat.
It definitely did, and it definitely sparked some conversation there. So this is wonderful. We do have 2 clarifying questions. The first one, I'm going to send over to Michelle. Was there anything about rural versus urban messaging?
We did not look at the data that way, but as I mentioned, we have a base of 500 folks. And so we could, I think the rural penetration was low. So let me just, I have the data in front of me and I can, yeah, we only had 13% living in a rural area that were surveyed, but still, a base that we could look at. And then while I'm going, I can touch on the social media question that's here as well. Oh, Caitlin, you got it. Facebook more than Instagram. Yeah, so the only thing I would add here is Instagram, it did pop for those under 55, along with Facebook, but Facebook and YouTube overall were most widely used.
Yeah, I was actually, I think Audrey, you were there too. We were at the WEO conference in San Diego a few weeks ago, and there was a really interesting presentation there about social media and raising awareness about colorectal cancer prevention. And they showed specifically in this age group, Facebook is the way to go. I think we all like to think of Twitter and Instagram, but we got to remember that if you're 45, 50, 55, 60, it's most likely Facebook that you established years ago and still have use of.
Wonderful, thank you. Thank you all for all of your amazing answers. I think you generated so much chat and people feel very invigorated with this conversation. And I'm going to transfer over to Caitlin to wrap us up.
Yeah, thank you so much, Yvonne. And again, thank you to our wonderful panelists. This has not only been great information that you shared, but a really wonderful conversation. And I apologize we weren't able to get through all of your questions, but again, this call is recorded. So we'll go back through and try to answer them for you after the fact. I also want to remind everyone that you can follow us on Twitter at NCCRT News. Please hashtag 80% every community. You can sign up for our newsletter where we try to share upcoming resources, our partners, events, cutting research, things like that. you can always take the 80% pledge and apply for NCCRT membership, and you can do all of that on our website. Just as a reminder, I know we've mentioned it a couple times, this resource will be available hopefully in the next couple of weeks or in the last kind of steps of getting it out to you guys. And again, please take our evaluation following this webinar. We really want to hear from you about what resources you're looking for, what sort of webinars you'd like to receive down the road, and how we can use this information to help increase screening rates in your community. So with that, I will close us out for today, and thank you all for joining us.